So the next talk is coming to us from the Brooke Army Medical Center and the U.S. Army Institute of Surgical Research. The title is Outcomes of Arterial Grafts for the Reconstruction of Military Lower Extremity Arterial Injuries, given by Dr. Laverty.
My name is Robert Laverty. I'm a PGY3 general surgery resident at the Brooke Army Medical Center in San Antonio, Texas. Today I'm going to be presenting our findings regarding the outcomes of arterial graft reconstruction in the setting of military lower extremity injuries. I don't have any disclosures. To give you a little bit of context into the issue, injuries to the lower extremity vascular system were amongst the most common seen in Iraq and Afghanistan. There have been a number of reasons theorized as to why this may be, to include the increased use of body armor, the more forward positioning of surgical capability, the penetrating and explosive mechanisms of weaponry in theater, the more widespread use of temporary shunting, rapid evacuation strategies, and just overall increased survival after wounding in these conflicts. Bypass graft reconstructions have been found to be the most common in the setting of these injuries. However, long-term outcomes in both the military and civilian settings is largely unknown. We sought to better elucidate these long-term outcomes and to look into their association with limb loss. To do so, we conducted a retrospective cohort study using the Fasciotomy and Vascular Injury Outcomes Database, which is a military limb salvage database that contains long-term follow-up data for military casualties injured in Iraq or Afghanistan between the years of 2004 and 2012. We queried the database for limbs that sustained at least one arterial injury that underwent reconstruction with a bypass graft. These injuries needed to occur to either the common superficial or deep femoral, popliteal, or tibial arteries. Our primary outcome was defined as composite graft complication, which included thrombosis, stenosis, pseudoaneurysm, blowout, and/or arteriovenous fistula. Ultimately, we identified 220 arteries, arterial injuries that subsequently underwent bypass graft reconstruction, 26 of which sustained a composite graft complication. Between the two groups of those that did and did not sustain composite graft complications, blast-related injuries predominated. Overall, and limb-specific severity scores were similar amongst the two groups, as were the presence of fracture, a nerve injury, combined arterial and venous injury, along with the presence of shunt or fasciotomy. However, we did find that graft complications were more common in limbs that sustained multiple levels of arterial injury, and those that were reconstructed with a synthetic conduit. Albeit, while the N and the latter group was low, we did find significance. We also looked into the association of graft level with the incidence of graft complication, graft level being defined as the most distal extent of the reconstruction. And while we found that the rate of graft complications were similar amongst these levels, we found that the type of or the distribution of individual complications differed amongst them. For example, thrombosis was the most common complication in femoral and popliteal grafts, while stenosis was the most complication in tibial reconstructions. We also looked into the association of thrombosis with amputation. We found that thrombosis occurred in 24 or 11% of grafts. 16 of these occurred within 48 hours and 13 in limbs that ultimately underwent amputation. 4 out of the 8 limbs that were reconstructed with a synthetic graft ultimately had amputations, 2 of those which thrombosed. We also looked into the temporal nature of these complications, analyzing essentially when they occurred. The median time to thrombosis was found to be 1 day, with an interquartile range of 1 to 3.5, but with an overall range of 0 to 182, underlining that these complications are occurring far from the index operation, emphasizing the need for robust and robust surveillance protocols in the setting of these reconstructions in both the acute and long-term setting. Found that the median time to aneurysm was 11 days, blowout was 25 days, and stenosis was 18 days. 2 arteriovenous fistulas were discovered at 1 and 11 days. Overall, we found that these complication rates are high. 26% exceeds the reported rates in the civilian trauma literature, which typically range from 10 to 20%, and that they're occurring far from the index operation, which again just really underlies the need for robust surveillance protocols in the setting of these reconstructions. Given our lack thereof, we're also likely underestimating their true incidence. We found synthetic conduits to be a clear risk factor for these complications, which does align with previous findings in the literature. And again, especially underlines the need for surveillance in both the acute and long-term setting after reconstruction with these types of grafts. We found that early graft thrombosis does occur, and it's associated with limb loss. These synthetic conduits should really be used only as a last resort when autologous vein grafts are not able to be harvested. Again, given our finding that graft complications are occurring more commonly in limbs with multiple levels of arterial injury, these limbs in which these synthetic conduits were used were probably more severely injured and likely and potentially without harvestable autologous vein. But again, surgeons should consider shunting as a bridge to autologous conduit if possible, or using short-term heparinization if other injuries do not contraindicate such. I'd like to thank Drs. Kauvar and Walters for their assistance in the project. And these are my references. Thank you.
Great. Thank you so much for that important work. And I just wanted to thank you also for your service. Dr. Laverty is a captain in the United States Air Force, and we wish you much luck as you move forward in your military career and also in your surgical career. There is a question coming from Dr. Church. What is the specialty profile of the surgeons between general, vascular, and cardiothoracic?
I presume that he means those that are located downrange in this deployed setting. It's a bit of a mixed bag. It depends on where these soldiers and airmen and sailors are being potentially injured. There are a couple different sort of what we call roles. They're different echelons of care that we have downrange, and the more further forward these hospital settings or setups are, like particularly specifically in like a role 1, the more likely that they will not be a sort of subspecialized care, so more likely they are to be general surgeons. But we do have vascular surgeons deployed downrange at some of the bigger, more fixed facilities. We did not analyze who, or didn't look into differences in between who was doing these repairs. So I don't have that exact data, but there are, kind of a mix of both.
Do you mind actually telling us a little bit about the patency strategy that I guess you in your study that you have noticed? Was there a certain patency strategy that was more successful in this study cohort?
In terms of like specific surveillance that these patients were undergoing, or in terms of other like
Well, for
adjunctive
example, for
therapies.
prosthetic, right. So for example, were these people managed on anticoagulants, antiplatelets? You mentioned thrombosis quite a bit as one of the longer late-term complications. And, you know, so I was just wondering, especially in the context of these are blast injuries, right? In the specific setting,
Uh,
how did your patency strategy play into maybe their other injuries or, polytrauma?
Absolutely. Yeah, the majority of these the mechanisms of injury were in fact blast injuries, specifically from IEDs. But unfortunately, the database that we use is a little bit
Mm-hmm.
limited in that sense. Downrange data collection is a little bit limited in nature, and so we don't have that information of whether or not these patients were systemically heparinized or anticoagulated. This is sort of essentially one of the goals from this study is to potentially develop a more prospectively set up study that analyzing subjects that are undergoing limb revascularization in the setting of trauma to sort of better delineate, better sort of explore the technical and functional outcomes of limbs to better inform potential active surveillance protocols. But kind of the bottom line is I don't think there were any,
Mm-hmm.
specifically in place, and so these are sort of some of the goals from the project.
That's great. Well, I think that military trauma and the outcomes of that I think are so important. And again, there's so many service members overseas that will benefit from the work that you're doing. So, what future projects does your group have in line after this to look at this? And
So absolutely. So I sort of mentioned kind of the need for a more prospectively focused
mm-hmm.
sort of cohort study that will, again, prospectively analyze these limb-related technical and functional outcomes of limbs that undergo revascularization in the setting of trauma. We have set up one at our institution, but the goal is to sort of establish more of a multi-center trial that again will better inform data on these outcomes, and then also that would in turn better inform our potential active surveillance strategies.
Well,
Still more
wonderful.
work to be done, but yeah.
Right. Absolutely wonderful. Thank you so much.